Good morning, everybody. I hope you enjoyed Dr. Bateman's talk. It was incredibly interesting. And now we have two wonderful speakers for you. My colleague, Courtney Bro at CPQCC, my beloved colleague, is going to kick it off. And with her partner, Dr. Ashwini Lakshmanan, both just such genuine, caring people. And we are so grateful that they decided to join us today. So both of you, I wish you a wonderful talk.
Thank you, Christina. We appreciate you. And really, we're so grateful to the planning committee, yourself, Marcy Treadwell, and Savannah Gray, and others for inviting us today to share our passion around disparities, social needs, and community connections in the NICU. I'm Courtney Bro, and I'm the Associate Director of Quality at CPQCC. And I'm honored to introduce a longstanding CPQCC partner and dear friend who is as passionate around this work as I am. But she quite possibly might have a million more connections than I do with experts in this field. And for that, I am truly grateful. Dr. Ashwini Lakshmanan is an associate professor in the Department of Health System Sciences at Kaiser Permanente School of Medicine. Thank you, Ashwini, for presenting with me today.
Thank you, Courtney, for having me.
We have no disclosures, and I am really excited to share our objectives today as they're creatively displayed here. This all begins with the beautiful neonate, of which data is critical to drive quality improvement, and to be able to look at the developmental and medical outcomes of NICU patients. Moving up, the family next is where stories are not only necessary, but crucial in this work. And we end at the top where we have the health system with values and opportunities, along with a great potential for innovative solutions. We've previously focused on mortality, health, and neurodevelopmental outcomes. But now, by prioritizing outcomes with follow-through and family, we can truly address the holistic needs of our NICU patients and families. Not only will this contribute to improved clinical outcomes, but it will also enhance the overall experience of care and support with long-term health and well-being. Follow-through encompasses the entire continuum of care, from initial interventions to long-term follow-up. It's about ensuring that our interventions have really, truly lasting impact, and that patients and families receive the support that they critically need beyond the NICU. And then equally crucial is the integration of family-centered care into our practices. And so recognizing the vital role that families play in the care of their newborns, we must truly strive to involve them as partners in the care process. This means fostering open communication and respecting their values and preferences, and empowering them to actively participate in the decision-making. Over the past 4 years, CPQCC has consistently and intentionally centered its educational conferences on the vital themes of health equity and actionable initiatives. We have partnered with our CPQCC teams to create tools to create change around health equity. So you can see the trajectory from 2020 to this year, 2024. And this year really truly marks the commencement of our journey, focusing on health-related social needs and forging critical connections within our communities. We will work with the NICU teams in building opportunities to collaborate with community resources to connect families with social support services and resources. NICU teams play a vital role in creating change with health equity by addressing disparities, promoting inclusivity, and advocating for policies and practices that ensure equitable access to care for all patients and families. CPQCC truly embraces a family-centered care approach, And in 2002, our yearly conference focused on families as the foundation of high quality, inclusive NICU care. Our goal is to ensure that the unique needs and preferences of patients and families are central to care decisions. This includes involving families in care planning, providing support services, and fostering a collaborative care environment. We would like to share CPQCC's Improvement Palooza 2022 highlight reel. And really what this shows is the impact we had with partnering with families and centering their stories.
And supports parents to act and feel like parents.
We hope that our stories will compel you to integrate families into NICU care and to recognize families as the most important member of their child's care team.
My feeling was that I had landed her here in this place, that my body had failed to protect her. Her life was in danger because of me. And that was not based in reality, but that is a very common feeling for NICU parents.
The non-clinical side of things really took a toll.
I remember having great anxiety. Is the only time that I'm going to be able to hold my baby when he dies.
Being in the NICU is challenging for any family. Parents are going through something they've never experienced before.
You had to just choose one lesson that you would like healthcare providers to take away from your journey and your story. What would it be?
Invite parents to attend rounds. That allowed me to feel empowered.
Take the time to ask them, what are the services that they are eligible for?
So I think one of the questions for providers, how can you systemically follow up with NICU families?
I think you really have to be willing to listen to families share their experience as they experience. To be able to advocate is a privilege that many people don't have. If you really want the truth of people's experiences, then you have to create a fertile environment for that to happen, and then implementing those changes.
Cultural humility for perinatal care is a key question. What if the experience is the outcome? We do this work around birthing outcomes, but what we've learned is that the birthing experience is that memory that our families think about.
My baby died the day before her first birthday. And just like that, we became the statistic. Black, college-educated women, twice as likely to have an infant die before their first birthday than a white woman who drops out of high school. My hope for you, having heard this, is that you will lean into examining your biases, ask more questions, forgive yourself for your missteps, acknowledge the value of parental wisdom, and remember that these infants are more than their saturation rate, their bilirubin, and milestone markers. They, like you, have a story, and their experiences with you absolutely inform the outcome.
It's really important that we work hard to keep babies and families centered in everything that we do. They are our inspiration. They are why we work hard every day to advocate on behalf of NICU families. I know that can be difficult for healthcare providers who are doing this work every day, but thank you to all of you out there that care for babies and families like ours.
Thank you for letting us share this powerful clip. We have so much work to do, and I am honored to be able to partner with families in this way. Thank you. I'm going to toss it over to Dr. Lakshmanan.
Thank you so much, Courtney. That video clip is always so telling and so powerful, and thank you for letting us share it. So where are we in thinking about our families, our health system, our social services, in designing an enterprise that meets families where they are? So this is a depiction from the IHI of the triple aim, quadruple aim, quintuple aim of how do we intersect families, primary care, costs, health promotion and prevention together and create a health system that really takes care of our vulnerable babies and their families. Next slide. So this is just a depiction from PubMed about where we are in terms of numbers of publications regarding family perspectives. And you can see over the last 10, 12 years, the number of publications has grown tremendously, over 700 publications and more than 500 of them in the last 5 years. Next slide. So in reviewing the literature, we can really distill it into the following domains: equity in care, mental health and resilience, financial burden, transition to home, and engagement with providers. Next slide. When we think about equity in care, next slide, we can think about the importance of implicit bias and what that means to our families. Here, we'd like to share the story of Jessica Wade, one of our parent partners and proponent of Mighty Little Giants. She was featured along with her family on a segment from Black Maternal Health Week in LA County here on Spectrum News. So we'd go ahead and like to share this clip with you.
Black Maternal Health Week sends 3 main messages: hear me, see me, respect me. I'm Ryan Blackshear Vargas in LA County with the story of one mom who's sharing her birthing experience in order to make birthing safer for other women. Hearing her boys laugh is always a sweet sound for Jessica Wade, especially her older son, Marlon Jr. She wasn't always sure she would be able to hear it. I didn't know he was gonna make it or not. 7 years ago, she got a surprise during an ultrasound. After first being told there was no heartbeat, not only did they find 1 heartbeat, they found 2. She had 2 babies growing inside, but she was also growing more concerned about a chronic cramping she was feeling. The pain just didn't feel right, so she reached out for help. I went to urgent care 7 times between 6 weeks and 21 weeks pregnant. And every time I went, they told me I was not crazy, but they said, go home, put your feet up, everything's okay. 7 times she visited different urgent care facilities and was told the same thing, but everything wasn't okay. She miscarried one of the babies. And at 21 weeks, she had to stay in the hospital on bed rest to keep the other baby alive. So she wore her pink PJs and waited. And on the 58th day in the hospital, she told doctors and nurses that she felt she was in labor. I was telling them, you guys, I know I've been here for a long time, but this is a different type of pain, something else was going on. They didn't want to check me because they didn't want to cause active labor, but I knew something was going on. So my mom had to drive from West Covina to Lancaster to make somebody check me because my husband had to get, he was on the train trying to get back up there. And they finally checked me and I was 10 centimeters dilated. So I literally almost gave birth in the hallway to my son. She and her husband welcomed Marlon Jr. He stayed in the NICU 143 days before he could go home. Jessica was relieved Marlon was okay, but she had to mourn the baby she lost and couldn't help but think how things could have been different if she had received help sooner. I'm sweating, I'm crying. Don't look at the monitors. Look at me the person. Black babies in LA County are 3 times more likely to die before their first birthday than white babies, and Black moms are 4 times more likely to pass away compared to white moms. Implicit bias is a big part of the problem, says Adjua Jones of LA County Department of Health Services.
So we've been able to finally acknowledge and identify that racism is one of the major leading causes, right? The impact of racism on the body of Black women and their infants.
These days, Jessica plays ball with a healthy 7-year-old Marlon and his 5-year-old brother. I'm a total boy mom. I would have never thought. My life is soccer, football, monster trucks, and wrestlers. And in her spare time, she started an organization called Mighty Little Giants to help other families with kids in the NICU. She's also a doula to high-risk moms, and she gives them all one piece of advice.
Listen to your body, listen to your first mind. Your body is always right, no matter what.
Listen so that more Black moms will be able to hear their children's laughter, too.
Thank you, Courtney. I think Jessica's story always stays with me because she always says, look at me, the person. And I think we all need to take that into heart as providers and the way we design different types of interventions. Next slide. So this was echoed in a seminal piece in pediatrics authored by Rachel Witt, Mia Malcolm, Eve Colson, and colleagues called Racism and Quality of Neonatal Intensive Care, Voices of Black Mothers. Next slide. And they highlight the various types of racism that families may face in the NICU, including institutional, interpersonal, and structural racism. Next slide. I think what was really compelling from this piece was the ideas for change that emerged. And families requested that they have more concordant care with increased Black representation, increased peer support, and improved staff education and training in the areas of racism and equity. Next slide. I think an interesting piece that everyone should take a look at if you have time by Beck, Edwards, Horbar, and colleagues is looking at the intersection of racism, segregation, and inequality, and how each of them affect lower quality of care, socioeconomic disadvantage, and can affect the health and well-being of our preterm infants and their families. And the issues that cause increased risk, such as access to quality perinatal care, increased intrapregnancy intervals, 17-OHP access and adherence, cerclage, and screening and treatment of specific types of infections, and how those intersect with socioeconomic disadvantage and lower quality of care. Next slide. One issue that's emerged is redlining and historic segregation and how that's affected birth outcomes, not only here in California, but widely domestically, including preterm labor, small for gestational age birth weights, and prematurity. Next slide. This is also transferred to our outcomes for both birthing parents and infants, including the association of race and ethnicity and morbidities for our fetuses, our infants, and their parents. Next slide. Now we'd like to touch upon the issue of intersectionality. What is it like to give birth in America, facing various types of barriers, cultural, language, perhaps work and employment? So this is a clip from a powerful series on CNN called Giving Birth in America. This is a trailer for our California segment.
Ya voy a cumplir en junio 9 años de estar aquí, en Guatzumil. Yo trabajo en la pesca de la fresa. Se supone que cuando ya estás en las últimas semanas es cuando más relajada tienes que estar, cuando más tranquila. Pero con la nueva administración, todo tenso.
About 7, Adrian Serrano. About 8, Kevin Perez Sanardo.
When I hear people in society say immigrants don't deserve the right to health care, the right to work, or the right to be here, I take that personal. And I take it personal because I'm from a family of immigrants.
Que ya anda la migra aquí, que ya anda la migra acá, y pues a veces hasta tiene un miedo ir al doctor. Muy fuerte.
What I'm fearful of is that patients neglect their healthcare because they don't feel that that's an option for them anymore.
And women can die.
Yo sentía mi cuerpo raro, diferente. Algo está pasando. Nosotros los papás siempre pedimos lo mejor para los hijos. Pues ya que me alivie y tenga mi bebé, pues ya a ver qué pasa, dependiendo las cosas. Pero cada sacrificio vale la pena.
Thank you, Courtney. I think sharing these narratives is so important to hear our patient stories. And this features one of our OB partners, who some of you may know, Dr. Christina Gamboa, and the work that she does in Northern California. Next slide. So one of the issues that our families face is intersectionality and what it's like to be a frontline worker. This is from the Labor Center at Berkeley, and the distribution of race ethnicity of our frontline workers. So most of our farm workers, construction laborers, cooks, food preparation workers are largely Latina, and how we need to understand their background and really talk to our families and see all the things that fill their plate as we care for them in our units. Next slide. I think some of you may have seen this slide yesterday, but we felt it was worth repeating because where are we as professionals and recognizing the types of disparate care that might happen in our NICU? And this was really important work by Krista Sergensen and Jochen Profit and colleagues, where they interviewed providers at our Vaughan meeting about what do they think about care that's provided in the NICU? Is there disparate care? And these are some of the themes that emerged, that perhaps there is neglectful, judgmental care. There might be systemic barriers that the staff are unable to face. There might be priority treatment and for assertive families and certain types of families with privilege. And language barriers may pervade all of this work, leading to suboptimal care. So I think, this is a wonderful first step, that we are recognizing where we are as professionals and providers. Next slide. This work was continued by Diana Monteiro Williams and colleagues. This is a wonderful primer published in New Reviews called Anti-Racism in the Field of Neonatology, a Foundation and Concrete Approaches. Next slide. And that really we can make a difference in all aspects of our care, that there are concrete strategies that can be explored in each sector: clinical care, quality improvement, research, administration, community engagement, and medical education. Next slide. This work has continued at meetings like PAS, as well as our new grassroots organization called the Neonatal Justice Collaborative, which is actually founded and led by a graduating fellow from UCSF, Kayla Caronin, and now has grown to more than 300 members. Next slide. And this work has continued at CPQCC. I'd like to pass it to Courtney to tell you a little bit more about CPQCC's commitment to health equity.
Thank you, Ashwini. As Ashwini mentioned, we are truly committed. And this is actually from our 2021 Improvement Palooza. And our amazing partners in this work, Dr. Valencia Walker and one of our CPQCC family leads, Jen Canvasser, spearheaded the curating of these activities that you see, these pre-Palooza activities to advance anti-racism in the NICU. So we invited all of our 2021 Improvement Palooza, which is our conference, attendees to complete a series of these activities. And this is just an example of the first tier, which is the foundational tier. And we built on that with the other tiers. And basically these were designed to prime NICU teams for conversations on how to create an anti-racist NICU. Another example of CPQCC committed to health equity is our health equity dashboard. This is an amazing tool for our CPQCC teams. It really allows NICUs to monitor equitable neonatal outcomes within their NICU. And big thanks to Jochen Profit for developing this. So as you can see, this tool displays key processes and outcome measures by race and ethnicity to really allow NICUs to see if and where disparities exist in care and inform them of opportunities for quality improvement. So basically, it's a snapshot of health equity in a NICU. And it's really a critical tool that our members use. And on the right, you can see the metric is human milk at discharge, stratified by race and ethnicity for small babies. And it's looking at our CPQCC network from 2018 through 2022. You can see our Asian population are doing very well along with the non-Hispanic white patients, but there are opportunities to drill down around our Black, Native Hawaiian, other Pacific Islander, and our American Indian and Alaska Native patients. We need to gain more insight into successes and barriers to both quality and equity. So it will be a critical opportunity to focus on these patients and implement potentially better practices, and then monitor the effects of quality improvement. Ashwini?
Thank you for sharing that with us, Courtney. I think another important domain is mental health and resilience when thinking about our families. Next slide. This was work published by Annie Hanvier and colleagues in Canada about how do families think about regret and resilience in the NICU. They surveyed about 250 parents, almost had 100% participation, and half reported they did not have any regrets. Of those who did report regret, the themes that emerged included guilt, regret about self-care decisions, and decisions about their parental role, wishing they knew sooner how to get involved, but none reported regret about life or death decisions made in the NICU. Next slide. How about resilience? I always find this interesting, that most parents predict an overall good quality of life for their child and focus more on familial impact. This was work from Dr. Ferrand and colleagues, and that parents are really have resilience, and there are different types of resilience that they need to seek during such a difficult time. Next slide. This is work that just was published this year in JAMA Network Open. It's a study from Germany about framing of information. And they did a randomized control trial where they provided information to over 200 parents with optimistic messaging first and then pessimistic messaging second. And no surprise, parents had a significant preference for optimistic framing when presented information in the NICU. Next slide. So all that to be said, that I think it's important to think about where family sources of resilience and how we can meet them as providers in terms of framing information. Next, families really have focused on financial burdens during their time in the NICU and beyond. Next slide. This was work published by Brian King and colleagues about the financial burdens that families face. And not surprising, it's transportation and care for siblings and time off from work. Next slide. Another big piece and time point for families is this transition. We've taken care of them in the NICU, and how do they make that transition to home? Next slide. This is a piece published on parent perspectives for discharge after NICU admission, and these are the themes that emerged from this work. It's important to have good communication, parent role, emotional support, knowledge and training, and good financial resources for families. Next slide. It's also our responsibility to provide good follow-through. This is our new paradigm. Next slide. That follow-through is distinguished from the more typical practice of follow-up, in which services and staffing of clinics are focused on medical conditions. Rather, follow-through focuses on our responsibility to practice both social and technical medicine as providers. Next slide. How about engagement with providers? Families in the NICU really get to know their NICU staff and are expected to interface with the medical system at a rate of usually 10 to 15 times more than the general pediatric population after discharge. Next slide. And this can look different for different families. One model that has emerged is family integrated care, and has had a positive impact in terms of neonatal outcomes and paternal involvement in childcare. Next slide. But has been associated with some feelings of parents feeling guilty for not being there as much as the programs may want them to. In addition, there are transition to care home programs, which focus on a multidisciplinary approach of supporting families over the first few months after discharge. This program is from Brown. Next slide. and also the focus on family advocacy and family-centered care, which I'll pass it to Courtney to talk a little bit more about.
Thank you, Ashwini. And just keeping on the theme of families, we are committed to partnering with families. And the FCC task force right there on the left is a partner of CPQCC's. It's led by Dr. Malati Balasundaram, who is a key PQIP partner of ours. And this task force is the first international multi-center collaborative initiative solely dedicated to quality improvement in family-centered care. So essentially, they support and exist to equip and support NICUs as they seek to initiate or strengthen family-centered care in NICUs. And the image on the right is a flyer that we developed for CPQCC's Family Advisory Council. So we have a council that was developed a few years ago, made up of a diverse group of dedicated families, and they lead and guide CPQCC in this work. And they also are there as a resource to NICUs to be able to help them build individual family-centered care initiatives within their NICU. And as Dr. Lakshmanan took a deep dive around all of these domains, we hope that you now understand that health-related social needs stand as a central pillar intersecting these various domains and is crucial for holistic and patient care and well-being. Health-related social needs serve as a critical focal point at the intersection of equity and care, mental health and resilience, financial burden, transition to home, and engagement with providers. And really, by recognizing the interconnectedness of these domains and proactively addressing social determinants of health, healthcare providers can advance equitable care delivery, promote positive health outcomes, and most importantly, empower individuals to thrive within their communities. I am pleased to present our faculty and moderators from our most recent conference, Improvement Palooza 2024, held on March 1st in Coronado. This was truly an exciting day. We had 149 total attendees, both in person and virtual combined. And we heard from these amazing experts around equity and advocacy and how to build connections outside the NICUs for our families. As I said, it was an amazing day, and I still am hearing the voices of these experts in my head today. There's so much work to do together, but we can do it together because we're stronger together, and we'll be able to create that change that is much needed. I want to give credit to one of our speakers, Jessica Wade, the one that was in the video clip earlier. She's the founder of Mighty Little Giants, as Ashwini mentioned, and she presented at our Improvement Palooza earlier this month around Maslow's hierarchy of needs. And in order to better understand what motivates human beings, Maslow proposed that human needs can be organized into a hierarchy. And these needs provide a framework for understanding the fundamental human needs that must be fulfilled for individuals to reach their full potential and achieve self-actualization at the top. And before providing support in the hospital setting, it's essential to ensure that patients' basic physiological and safety needs, as outlined in these hierarchies, are met. And this hierarchy ranges from more concrete needs such as food and water to abstract concepts such as self-fulfillment. And of course, you know, when the lower need is met, then the next need on the hierarchy becomes the focus of our attention. And really, I'm reminded, for those that attended the conference yesterday and heard from the Packard team around their health equity rounds, I'm reminded what Dr. Razdan said. She said, race and ethnicity is a social construct but lived experiences are critical to understand. And so we can leverage this hierarchy to help us better understand our patients' and families' lived experiences. And the key to that is truly listening. I'm going to go ahead and turn it back over to Ashwini.
Thank you, Courtney. So how do we define this as a health system and as providers taking care of families? I often get confused. What are social determinants of health? What are health-related social needs? So for the purposes of today, this is how we're defining them, which is from the CDC and HHS definitions. So social determinants of health are non-medical factors that influence health outcomes. They are the conditions in which people are born, live, learn, work, play, worship, and age that affect a wide range of health risks, functioning, and quality of life. While health-related social needs are social and economic needs that individuals experience that affect their ability to maintain their health and well-being and include needs such as employment, affordable and stable housing, healthy food, personal safety, transportation, and affordable utilities. Next slide. So we can think of social determinants of health as the community level factors and health-related social needs, which may be unmet as our individual level factors. Next slide. So this is an infographic from the Healthy People 2030 Social Determinants of Health graphic from HHS that looks at the various domains: education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability for every one of us. Next slide. This figure is also from the Office of the Assistant Secretary for Planning and Evaluation from the U.S. Department of Health and Human Services, and kind of depicts where we are from individual impact to health equity and sector impact across holistic care to community impact. So downstream in healthcare, we can try to address individuals' healthcare needs, hopefully providing equitable delivery, improving access and referral networks, to coordination across sectors midstream, to upstream affecting community and government. Next slide. This is from Dr. Meg Parker at University of Massachusetts on how we can think about all of these constructs as under one umbrella. It's not just race, ethnicity, as Courtney and Dr. Rosdown pointed out, but it's completely lived experience, which can intersect concepts such as poverty, unmet basic needs, racism, neighborhood and built environment, language and cultural disparities, and adverse environmental exposures. Next slide. There's been a plethora of work in this area in recent years, which is very heartening, especially in pediatrics, around how to address poverty and child health in the US. How do we implement screening, and how do we respond as professionals in health systems? Next slide. This has been advocated for by the White House. This is the US playbook to address social determinants of health, which was published late last year, as well as the Health and Human Services call to action to address health-related social needs in communities across the nation. Both are great reads if you have time. Next slide. The call to action specifically looks at that half of variation in health outcomes is due to social determinants of health. That transformation can happen through backbone organizations such as these, and that we should expand capacity for community-based organizations to serve as hubs, engage our health systems and clinicians, document health-related social needs as Z codes, identify financing mechanisms within health systems to help fund these screenings and referrals, partner with public health agencies, and incorporate health IT. Next slide. There's been also support in terms of external requirements from CMS, increasing payments for meeting 3 health equity measures. Next slide. As well as from the Joint Commission, who have new requirements to reduce healthcare disparities. Next slide. They want us to assess patients' health-related social needs and provide information about community resources and support services. Next slide. It also has become important in various rankings to use patient data collection and use and to address disparities and equity in all our work. Next slide. What is the relevance for at-risk infants? So this is particularly important for our parents of infants born preterm who are disproportionately low income. A quarter of US families with preterm infants have unmet basic needs such as housing or job security. It's overwhelming to think that 26% of families experience food insecurity, 33% housing insecurity, and 28% energy insecurity. Next slide. This is work from Gabby Cordova Ramos around social risks among families of preterm children. This is looking at term babies in the first column and preterm babies in the second two columns, and are very tiny ones, less than 1,500 grams in that last column. Almost half of families are low income, and a third to 40% of families suffer from food insufficiency, financial hardship, and have difficulty paying bills. Next slide. And what about the associations of social risks with developmental and child health status? Meg Parker and colleagues looked at the number of hardships that families face and the association with developmental risk and child health status. And we can see the effect estimates are much higher with one hardship and exponentiate with 2+ hardships. Next slide. How are we doing as NICUs? Are we screening for social determinants of health or health-related social needs? So Gabby Cordova Ramos and colleagues surveyed our division chiefs and found that about a quarter of US NICUs have a standardized screening process. There was no association between NICU characteristics and use of screening and referral tools. Next slide. So this is representing Gabby Cordova Ramos, the first picture, and Meg Parker's work around a local QI initiative they did in Boston that then expanded from their medical center to the state around integrating social determinants of health screening and referrals into their NICU window. They first looked at determination of eligibility and timing of screening and tried to figure out when was the appropriate time to do a health-related social needs screener. They then performed what they called Thrive screening. And the questions were verbally asked in a structured conversation format and then recorded in Epic. They then provided resource guides and discussed it with their social worker on their social work rounds. Next slide. The context for their study was that it was a level 3 NICU with almost 3,000 births, mostly publicly insured, 50% non-Hispanic Black, and they had one social worker. And all families in the NICU received at least one social work consult. Next slide. With no screening tool in place. So they first looked at local implementation of social needs and screening, and then created an innovative model of dual breastfeeding support and counseling and social needs navigation, and provided dissemination of efforts across the state. Next slide. This is their local implementation process of gaining family voice and multidisciplinary staff input, creating a screening tool and resource guide, and then performing multiple PDSA cycles. Next slide. Some of the family perspectives that emerged from screening were that there were untold worries and fears. Families felt like they had negative lived experiences with social services and felt like they were failing at parenting by disclosing needs. There was a fear of intervention by CPS and losing custody of their children, and there was some frustration at the prospect of disclosing sensitive information. Next slide. Staff, on the other hand, were worried about engaging in conversations about social needs. They felt like there may be unequal power dynamics between providers and families, and perceived a lack of efficacy to address these needs, and felt like they had insufficient knowledge about resources to counsel, and didn't have enough time to discuss social needs, and were concerned about language barriers. Next slide. They went ahead and proceeded, created a tool in Thrive based on previous validated work in something called We Care, which had been implemented in other settings, and did adaptation procedures. They did some focus groups and had bi-monthly meetings, and educated their staff about revised tools. Next slide. This is their Thrive adaptation. Questions were, do you have trouble getting transportation for appointments? Do you need support getting transportation to or from the NICU? Next slide. Are you interested in more education? Do you need more support for education in your house? Next slide. This is an example of their overall Thrive measure. They had a disclosure statement. They were targeting the household, asking about social risk and needs, and giving examples of what assistance might look like. Next slide. To integrate, they leveraged their existing resources, had champions or resource aggregators, contacted community agencies, made choices about optimal resources, and developed information sheets and iterated on family feedback. Next slide. This is an example of their resource guide from massthrive.org about housing resources. Next slide. And provided additional information on wraparound resources and universal resources beyond screening. Next slide. And so they really tried to integrate family-centered needs and staff needs. So they wanted to foster trust, empathy, dignity, respect, minimize stigma, and also minimize time documentation burdens on staff, increasing staff comfort, knowledge, and skills. Next slide. They had multiple PDSA cycles with trainings of nurses, residents, step-by-step guides, creating what they call Thrive stations with the resources already printed. Next slide. And this was some of their outcomes, that they had improvement with number of families screened over time over multiple PDSA cycles. Next slide. And had increased rates of connection over time. Rates increased up to 50% in terms of families receiving resources. Next slide. They were able to also broaden these outcomes to breastfeeding at discharge and saw an increase in percentage points pre and post intervention. Next slide. They also looked at equity and implementation at the percentage of families screened by race, ethnicity, and primary language. Next slide. And then broaden this to statewide screening, including the number of families approached for social determinants of health screening over time. And that clearly increased across various sites. Next slide. They asked families if they desired a screen and if they were positive on their social determinants of health screening and if they wanted assistance. And as you can see, up to a quarter of families had a positive screen, particularly around transportation, but almost 100% wanted assistance if they screened positive. Next slide. They also looked at various social types of risks across various centers to see if those needs were different at different medical centers, and they were. For example, the green indicated Boston Medical Center, which is in the heart of Boston, and more families were struggling with transportation there. Next slide. So overall, we need to think about our health system, social determinants of health, and structural inequities across the maternal-child continuum. Next slide. Next slide. And think about innovative care models such as community-based doulas, midwives, birth centers, establishing PQCs. Next slide. This is a screenshot from our Los Angeles County African American Infant and Maternal Mortality Initiative, which sort of encompasses a lot of those innovative care models. Next slide. And some of the concordant care models, such as UCSF's Embrace and Bloom Clinic, which has a new Black baby equity clinic to help infants and moms flourish. Next slide. As well as community-based efforts such as Mighty Little Giants, which we talked about Jessica's work. Next slide. So I think there's a lot that can be done in terms of models. One unique and interesting area is health IT. So I'll pass it to Courtney to discuss health IT and our efforts with CPQCC.
Thank you, Ashwini. I think in the interest of time, I think we've got a minute left. Is that right, Christina? Just want to make sure that we're on target
yeah,
here.
But I think you're going to be fine. Choose whatever to do what you want to do, Courtney. It's all good.
Okay. So I'm going to just quickly run through the leveraging the technology here and just make you aware of some opportunities that are available. So Vaughn, the Vermont Oxford Network, is a critical partner of CPQCC's, and they have these modules that were developed by Dr. Cordova Ramos and Dr. Parker. So you can access them, but they really help with the introduction of social determinants of health, social screening and tool selection, et cetera, et cetera. So please look them up. Just wanted to acknowledge them. And then another useful tool is the SDOH Information Exchange Toolkit from the Office of the National Coordinator for Health Information Technology. And this really focuses on the foundational elements for communities. So we've also had some research done by our own Dr. Lakshmanan around mobile applications to support parents in transition from NICU to home. And they looked at multiple health applications and this was a narrative review of all the literature. And there are several studies that look at mobile health applications, and only a few of these looked at forward-facing technology for patients to support them in the transition from home. Hopping back over to Vaughn, Dr. Horbar and his team were able to identify potentially better practices with regards to follow through for NICU patients and their families. So I'm going to skip ahead, and in our planning, CPQCC is planning a health-related social needs collaborative. We leveraged the input from our Improvement Palooza attendees around these following questions. And we heard from them that we need to begin to connect the dots and become aware of the community resources. I am so excited that this chat is on fire right now. We want to hear from you. So thank you for all of your leads in terms of making us aware of who these community resources are. And we are aware that they're going to be different throughout the entire state, county, et cetera. So, we want to think about how we can make certain that community resources are maximized to their fullest potential. And what are these specific care options related to palliative care and concurrent care? How can we actually encourage and support our families around being with their babies? Parking vouchers, I'm sure there's a lot more. How do we support them around childcare, food, the transportation, and then the electronic health record? And really starting to hardwire these practices. So skipping ahead, as we leverage the voices of our NICUs that attended Improvement Palooza, we wanted to hear from them around the resources which would be helpful to them. And you can see here the comments with regards to legislation. How do we show value? What are these screening tools available? We can leverage the work of our colleagues out east. What is the financial and business knowledge, the analysis and discussion around that? We have a lot to do, but in the history of doing CPQCC collaboratives for over the last 18 years, what we've learned most critically is that we need to center not only the family voice, but also our NICU voices in this work. So this is just a start for us to be able to launch from and move forward. So as I mentioned, with our upcoming unmet social needs related collaborative, we are prioritizing the resolution of unmet health related social needs, and it's really a key focus for CPQCC. As we do with our other CPQCC collaboratives, we'll leverage the IHI model, and we've had success with creating measurable change with our previous 11 QI collaboratives, and we'll move forward and create new opportunities for our NICUs and for their families to be heard. So contact me, please, if you are interested in partnering with us in this way. And apologies for going over a few minutes and taking from the Q&A. So I will stop there. I'll stop sharing my slides. And thank you so much, Dr. Lakshmanan. And I'll, of course, thank you to all of you for being here. We appreciate you, and you are critical to this work.
Both of you, thank you so very much. And the comments shown that your this talk was very much appreciated. I'm going to ask you guys to stay on now. I want to have a kind of a robust discussion. I want to share a few slides first to show a little bit about some work that's going on at our organization at CMQCC. So hang in there with me and then we'll start the discussion. So California Maternal Quality Care Collaborative. For those of you that don't know, we are the state's perinatal quality collaborative. One of our esteemed partners is the California Department of Public Health. I'm happy to have my colleague, Andrea Ferroni, on the call. Shout out, Andrea, this morning for joining us. So let's talk a little bit about what we've got going on at CMQCC. We've got several initiatives going on, including the slide you just saw about our low-dose aspirin campaign in relation to improving the situation with preeclampsia. We also have a community birth partnership, many resources on that. If you want to check out our website, we've had recent webinars on really setting up successful partnerships, doulas, midwives, physicians. And so we've got lots of resources on there. This was almost a 5-year collaborative, three to 4 year collaborative with 5 hospitals in California, both from Southern and Northern California. They really led us in this work and pointed out the right directions for us to take. So I want to highlight one of our resources that we have now available for every hospital in California that has birthing services. And this is the module overview. So there are 6 modules in the action guide. They have been written, authored, edited by multiple folks of the state, all over the state, various backgrounds, bring a lot of life experience to the table, diverse views, diverse histories. And we're very grateful to them for all being on our task force, acting as authors and editors. So these are the 6 modules. What we do in it, it's not like it's a big research effort. We can't wait for the research. We are in a situation now where we have to do the work now. So in the action guide, we point out learning opportunities, and then we go ahead and actually want you to take action. So it doesn't mean you're going to go in and read 50 pages of a research article. We want you to go ahead and take action. So we identify action steps, and then we go ahead and share resources. So as an example, this is about promoting diversity imagery, reviewing policy in your organization. Sorry, that was a bit awkward. Reviewing policy in your organization to look at policies such as toxicology screening. We know toxicology screening is not appropriately utilized in all facilities in the state of California, as well as nationally. So the resources available, we would love you to take us up on it. And I'm going to start us off in this discussion. And it's not an easy one, and we have to talk about it. And I want to thank the attendee that entered this question. How are providers? So let's widen providers. Providers meaning, let's do all clinicians, let's do nurses, let's do doctors, let's do midwives, hospitals being held accountable for racial discriminatory harm towards patients that struggle to advocate for themselves. Do either one of you want to kick it off, and then I'll add? Ashwini, are you able to kick us off?
I can start. I think that is, I saw that in the chat and I thought that was so important, right? Because accountability for whatever we do at work, personally or professionally, is critical. And I wonder, if there are standards within our units, whether we're on the obstetric unit or in the neonatal unit, among ourselves and our peers in terms of sort of critically thinking about this, that if families are feeling unsupported or that they're subject to racism, that we hold each other accountable for those types of actions. And maybe it's things as simple to start with as sort of peer review with our colleagues and having those open and honest discussions about our biases that may affect our patients each day. So those are just some early thoughts, and I'll pass it to you, Christina and Courtney, if you have additional ones.
Oh, that's wonderful, Ashwini. And I think I would just add to that, data is critical. And so we can collect qualitative data around this, and we have in the past, right? So it's important that these stories are told by these families. And it's important to follow up on that and transparency around that and being able to identify and take responsibility and then move forward. So I think accountability is huge. And I'll just use, the quality improvement framework where, data tells that story and that we need to acknowledge that and then move forward with our PDSA cycles to be able to address these and be accountable for what has happened.
We have a problem. I'm going to reframe it. We have an incredible opportunity in healthcare to improve upon the distrust that exists in healthcare today. I am a white woman, born, raised in San Francisco, California. I didn't know about Juneteenth till a few years ago. We need to educate ourselves as healthcare providers, clinicians, champions, and then go ahead and have very frank discussions among our colleagues, with our colleagues. We need to feel comfortable. We need to, I'm going to rephrase that. We need to feel uncomfortable.
Yeah.
Mm-hmm.
Have to get over our own discomfort. I make many mistakes. I'm one of the leads in our equity work at CMQCC. I make mistakes all the time. Those are my mistakes. I need to own them and I need to move on because I am a nurse. I am an advocate for patients, all patients. And this is really on us. So accountability, you've got the side that's on us truly. The other thing you should know is finally know that the regulatory agencies have stepped in. CMS, Joint Commission, and others are finally stepping into the health equity space. The state of California is. There are some requirements, according to training and things like that. As being a perinatal provider, bias training and others, but there's a lot more that goes into it. So more discussion has to be had about these issues, these opportunities on our units and with each other. So I'm trying to see what other questions there were here. I don't see any more here.
While you're looking, Christina, I'll just add to that, just in reflection of what I've seen in the chat, which I couldn't agree more, is the importance of doulas sort of across the care continuum. For us, postpartum, I think that is such an important resource in our workforce to think about, to have these frank discussions, and honestly, for our families, might be an impartial party to speak to, because it can be really overwhelming to talk to your provider, right? To your nurse, to your physician, to your nurse practitioner about your sentiments around your care, and sometimes that person who you've developed a relationship with over the arc of your care might be the most appropriate. So just as a reflection of, the wonderful chat that I saw going on, and just an additional push for integrating our care models.
Thank you.
Yeah.
So is it okay, Courtney? I'm just going to respond real quick. Are there programs being developed to get doulas in the door at the hospitals and spaces? That is one of the roles we're playing at CMQCC, or one of the aspects we're taking on, because we work with hospitals across the state and we have to speak about doulas and teach about doulas, what they do. I sit on several community organizations devoted to the Perinatal Equity Initiative in the state. So I attend, Contra Costa County, Alameda County, San Francisco County. There are 11 counties in California that are devoted to Perinatal Equity Initiative. If you can, go ahead and check that out. It's at the Department of Public Health, PEI. 8 8 births. I had the slide pulled up and now I don't have it pulled up anymore. Let me get this right. So in California, 1 in 8 US births occurs. California needs to lead. When California leads, other states follow. I think we're going to end it there.